I don't know logistically how we're gonna do this, so,
We'll
let somebody
snuggle
step
that.
up to the mic when they get a question.
Yeah.
You know.
yep, oh, that's a good idea.
Danielle with one more chair.
Oh, okay.
Enough chairs for the panelists.
I don't know, do you, Commissioner, do you wanna facilitate, and then I can make this chair available?
Sounds good to me.
Yeah, but thank you all very much.
You're welcome.
You're welcome.
Jenny, thank you for facilitating and panelists. Thank you for your responses. Really well,
Our pleasure.
very well done. All right, we'll have some Q&A for the panelists, and after that, we'll have any comments or general discussions, and we'll end at 12:30. Don?
So I'm probably not going to be able to get to all of these questions, but the first one regards reference pricing. I was wondering if the carriers could talk a little bit about whether or not they've thought about using reference pricing in setting reimbursement rates.
Sure.
You can start. I started last time.
Again, that's an area which we are certainly exploring. I wouldn't say that we're deep in that at this point in time, but it is something which we see for the future. It's being done more, being looked at even more closely on the pharmaceutical side of things. I think that's a little bit of a natural area for it.
Yeah, I would say that reference-based benefits have been somewhat constrained by the out-of-pocket maximum concept. I think reference-based reimbursement is interesting, and I think it has potential within categories of service, so we would consider that as well for the future.
And again, I would just echo that. We're certainly looking at it. It's a hot topic, and we're looking at everything we can do to make medical care affordable, insurance.
Great. Another question was regarding the last panel. They touched a little bit about the fact that some high-cost drugs are minimally effective. This attendee wants to know if there should be legislation that calls for a minimum efficacy for new pharmaceuticals that get approved by the FDA.
So I'll take that one. So
Good for you.
thank you. Somebody's got to dive in, right? So I would never debate whether we need legislation or we don't need legislation. Okay, so I'll take the middle ground right on that. But I think if you go back and we've all kind of talked about this, that you've got to continue to look at the value, okay, of what's coming on the market. You've got to continue to look at the clinical value of what comes on the market. Legislation, I think in many cases, points you somewhere. The question is does it necessarily point you to where you need or want to go? I would argue that as we look at drugs or as we look at any other component of the medical dollar, we have to sit down and have collaborative conversations. There's a lot of real good people on all sides of that, and we've got to come to some consensus on that. And I would say that's probably a necessary step, in my view, before legislation necessarily points us somewhere.
I guess I would, as a clinician who sees all the new drugs that have come out since I started, and again, Brian, thanks for saying that you're the oldest. I don't think so. But I think one of the things we need to do is ask that the organizations we already have out there, like the FDA Advisory Board, be listened to. So when new drugs come out that cost close to $1 million a year, that there has to be some proven efficacy, and not say, okay, well, there's no other drug out there, so we'll approve this one, when in fact it doesn't work for most people that have this particular disease. And then if, God forbid, the drugs come out that cost $1 million a year because they're being pushed by people who pretend to be advocacy groups but are in fact pharmaceutical reps, that we're allowed to have prior auth policies that say, okay, it was 4% effective for this small section, don't make us okay it for the other 96%. And so I think that's the big thing. And I don't mean to be terribly negative and frustrated, but you can see it hit a point with me, because it's not our money, it's finite dollars, and there's just no way possible to have more and more drugs come out that their own advisory committees say are not worth pushing forward that cost $1 million a year per patient. It's just not sustainable.
Correct.
Yeah, I was going to say a lot of what Bill just said. I would only add, and I would dare to go down the road of, to the extent we were going to look at legislation, I think really focusing on efforts around, cost transparency and data around efficacy would be the route to go in terms of legislation, and then let us understand that equation and let us craft as Bill kind of mentioned, our prior auth policies around that.
And just to add to that, I would say I do think that when you boil it down, what we do for our customers is we find the value. We have to procure for them the best value that our system has to offer, and I think we need to be able to continue to do that in different ways, including pre-auths. I think just bringing it back to the here and now as we decide what drugs are on our formulary, I think it might surprise, I hope it doesn't surprise people to know that when we all use, I think, something similar, a value assessment committee to make those decisions. And it is always a clinical decision first, and only when agents are clinically equivalent do we then make the cost decisions and look at which manufacturer has the best option. So I think that's part of what we have to do, is constantly do that work on your behalf as purchasers, especially as these new drugs are coming out with astronomical price tags.
Great, thank you. This next question, there are a couple of questions about premium rate increases going forward in 2018. It's been announced that in the individual market, for those members that are unsubsidized, they're going to see high increases up to 50%, or actually an average of 50%. What are some of the key drivers of these increases, and what do you think is going to happen in 2019?
Was the question on the individual market, or?
Well, we know that the rates are
Yeah.
going up substantially for those that are unsubsidized in the individual market, so this question is specific about the individual market, but you can take it more generally if you like.
Well, I'll just say, I got out of the prediction game after the 2016 election, but so I won't speculate about what's going to happen. I think, that there's, as I kind of referenced in our initial discussion, there's a robust public policy discussion going on in Concord with the Premium Assistance Commission that was administratively attached to the expansion of Medicaid and the premium assistance population. But I'll just say this, and then I'll let Lisa and Bill add to it, that, frankly, instability and volatility that's going on in Washington, D.C. in our politics right now is not helpful to the insurance markets. We need to be fostering environments that create competition, that maintain competition. And frankly, right now, what we have is a political dialogue in Washington and an ideology, maybe, in Washington that's not conducive to that. And I think you're seeing that play out in the individual market in New Hampshire and around the country.
So I'll say once again that I think the Gorman report did a really good job of breaking down what drove the high increases in the individual market. And I think, we saw a piece around the utilization, and you saw what the drivers of that utilization looks like. I think it's a fact that the PAP population and their claim costs in certain categories are a contributor, but that is not to say that's the only one by any stretch. This is also the year that the ACA insurer fee came back. That's worth several points. It was really a combination of things, but loss of CSRs definitely contributed several points to that increase. And then, as you always have to do in insurance, you're trying to trend forward and predict costs over a long period of time with great uncertainty about who would remain in that risk pool next year. And our greatest fear appears to be coming true, that without those subsidies and the like, we will see more young, healthy people leave the market. And we'll have to, a smaller group of people will have to bear those costs. That's what insurance is spreading the costs across a group of people. And I think that the changes in that risk pool are of concern as we go forward. We had a very hard decision to make about whether we even felt it was safe to try to stay in next year, and in some markets around the country they decided they couldn't. I was really pleased that we found a way to stay in. It's unfortunate that it takes those rate increases to cover the costs, but if you want to really understand it, I would go right into that Gorman report, which breaks it down pretty nicely.
Yeah, and I would just agree that, the uncertainty just made it difficult for us. I mean, I have to thank the Department of Insurance for constantly being on the phone with, I suspect, all of us, really trying to work on a way to make this work for everybody. I mean, we see it, it's in our mission statement. We serve the citizens of New Hampshire. We really wanted to stay in, but it was with a lot of back and forth. But again, if we could get some sort of certainty about who's in the market, what's going to happen with the subsidies, the taxes, I think that would go a long way to make it be less volatile. But again, uncertainty always adds to the cost, just not knowing when you're the one taking on the risk.
Great. We have time for one more. Talking about select and limited networks in New Hampshire, do you guys think that they have been effective in New Hampshire, and if so, more or less in other states?
I know our limited networks or high-value networks that we have are absolutely have been helpful. Again, it's gotten us to the table with providers to really talk about it, talk about the benefits of it. Again, I understand that it adds a level of complexity, but I think it's really helped. I mean, our Elevate Health product has consistently been 10% lower over the last 3 or 4 years since it's been in place than the same deductible, same copay, same everything. So it's been I think they've been effective at trying to keep the cost down. 10% is a lot.
Yeah, well, I guess what I would add is that while I think it's effective, its adoption rate has been slower than you might think it should be. Employers tend to look at it as a potential discrimination against employees who use one particular provider and not another provider, and so they've avoided it. Even though there's a substantial difference in premium, they tend to avoid that type of product type.
Thank you very much, Don, and thank you to the panelists for the really great discussions on all of the topics that were brought up here today. Let me open it up. You folks can either stay where you are or go to the audience. And
Go to the audience.
anyway,
want to run for it?
thank you. Let me just open it up for about 10 minutes or so, for general comments or additional questions you may have. And then we'll close the hearing. Yes, sir.
So the Trump administration is waging a guerrilla campaign against the Affordable Care Act. Not much of a guerrilla campaign, it's kind of right out in the open, but and since the expanded Medicaid program in New Hampshire is based on the Affordable Care Act, and there's also discussion of bringing that down on the part of the Republican majority in New Hampshire, what contingency planning are the companies engaging in terms of something to replace that?
To replace Medicaid expansion?
Well, to replace Medicaid, that's 45 to 50,000 people right now. I don't know how many people are insured under the Affordable Care Act in New Hampshire, but it's probably, what, 50,000 people, something like that, guesstimate. That's 100,000 people who could lose their insurance in New Hampshire if the Affordable Care Act goes away, and 50,000 if expanded Medicaid goes away. So what is the alternative other than legislation?
Well, there's a robust discussion that continues to go on in the legislature regarding Medicaid expansion that we have participated in. I have, Jenny has, Tyler has, Michael, and hopefully it ends up in a good direction, but certainly can't predict what's going to happen there. As far as the ACA is concerned, if we tried to speculate on every shift and move and parry that was made at the national level, I'd have to have 10 times the staff that I've got now. So I can't answer. Do any of the carriers have an answer or have a speculation on where these things might go? I doubt you'll see any, but maybe somebody's got speculations.
Well, I'm not talking about speculating. I'm talking about what contingency planning are they doing in the likelihood that this is going to happen?
Do the carriers have any comments about contingency planning? Yes, sir.
Commissioner, I'll just add that at least in the discussions that I participate in and with our organization and other carriers, I don't think the focus is on contingency planning. I think the focus is on how we're ultimately going to reauthorize our program in some construct to serve the population that's being served that needs to be served. I think from what I've heard, and I've referenced it several times today, and again, I've Representative Rosenwald sitting right here, who's a member of that panel, and I know Lisa Gerton sits on that panel as well, but the dialogue in terms of the premium assistance program and Medicaid expansion that I've heard is really centered around how we're going to do it and not if. And so the first time we expanded Medicaid and when it was reauthorized, we undertook a kind of a unique New Hampshire model, right? That resulted in placing that population onto the commercial market. And so, I know that my organization, and again, from what I hear from other carriers and other providers and other legislators and policymakers, is we're pretty keenly focused on figuring out how we're going to do this and not whether or not we're going to do this.
Great. Thanks, Chris. Any other comments? Yes.
I guess I'd like to have a little bit of an understanding from the experts in the room, what they see as the consequences of some of these policy shifts to the markets. And some of the policy shifts are, what if people don't sign up for the marketplace? And what if the PAP population, because of this commentary about high pricing, is moved? What happens to the marketplace, and what kind of canary in the coal mine effect does that have on the insurance markets as a whole?
Anybody want to take that question? Yes, Dr. Brewster.
So again, I can only speak for our Harvard program, but I'm assuming the others. We're in this for the long haul. We certainly, those are great questions. We understand that the PAP population could move. We've thought about it. We're ready. No matter what happens, we're in this for the long haul. So we will continue to insure people. There are certainly good parts of the ACA that, as a clinician leader, I don't want to go away. We will continue to cover things when we continue to cover things that are attributed to the ACA now, with a level set playing field for all of us to cover screening mammograms and colonoscopies. So I think it's an excellent question. We talk about it regularly. What time frame that we need if things should dramatically change. I'm hoping that there will be level heads in Washington. I know the governor and the DOI and all, we talk about, kind of preparing for things, but that there'll be enough notice so that we're ready and can redesign something and keeping some of the good parts that we need to keep.
I'll add a little.
Yeah, Lisa?
Yeah, I was going to say something very similar. I think, first of all, the immediate question about Medicaid expansion, I think one of the things we should feel good about, at least I feel good about in New Hampshire, is that the group that's been convened to look at that is a broad group that has the insurance department, HHS, providers, insurer representatives, and as Chris said, the focus right now is on how do we keep serving these people, not if. Of course, it's always subject to even bigger change coming out of Washington, but that's where I think you say we're committed. We've been through a couple cycles of this now, of having to really step back and say what's being reinvented and how are we going to react to that. I think we're feeling some of the consequences of it now in terms of these cost increases. There's a direct cause and effect between the uncertainty and some of the changes coming out of Washington and those increases. So that's an immediate consequence. But in terms of what might be around the corner, I think I agree with what you said. We're here. It's our industry. It's our job. We have to figure it out. We're very fortunate to be in a state where that's done in a collaborative way, and we wait and see.
Yeah, those are the assurances that I've been given too by all of the carriers that participate here. We are fortunate to have carriers that are going to continue to participate and have committed to do so. So I'm very hopeful that whatever the federal government ends up doing, as Dr. Brewster said, gives us sufficient time to be able to move on it, whatever that means. Any other comments? If not, thank you very much for attending. Appreciate it. I don't know if there are still goodies out there, but if there are, help yourselves.